The aim of this resource is to provide you with a very basic introduction to nystagmus, one of the most challenging ocular motility disorders you will study towards the end of your second year and in your third year. I will also be summarising some of the work that staff and students have done following the annual Nystagmus Network Open Day, which took place in May 2015. Before discussing our work from the Open Day, I'll just explain briefly what nystagmus is, how it presents in children and adults, the classification system we orthoptists use to describe the nystagmus, what it looks like and how it's managed in clinic. All this will be covered in much greater detail by lecturers later in your course. The definition of nystagmus given in Ansons and Davis is that nystagmus is a rhythmical oscillation of the eyes in which fixation is broken by slow eye movements and not saccades. Its appearance can vary, which will be shown later on in this resource. Just to bear in mind, this resource will be discussing pathological nystagmus only, not physiological, for example endpoint nystagmus, which occurs normally in extremes of gaze. The mechanism for causing the nystagmus movements are not known for sure, but it's thought that damage to various nuclei in the brainstem that act as neural integrators, which allow the eyes to maintain steady gaze holding, could be responsible. Nystagmus is associated with reduced visual acuity, the levels of which can vary broadly between patients. One study showed the prevalence of nystagmus to be 24 per 10,000, and certainly the condition is not uncommon when working in clinic. People can be predisposed to the condition, for example those born with albinism or those who develop infantile esotropia. Nystagmus can also be acquired, mainly in adults, as a result of a lesion to the brain. One of the most obvious differences between the symptoms of inherited and acquired forms of nystagmus is that children who grow up with nystagmus adapt to it and do not see shaking objects or a moving environment. In contrast, adults who acquire nystagmus do experience these visual symptoms, called oscillopsia. In childhood, nystagmus is more commonly infantile in form than acquired, where the condition appears within the first 3 months of life. Infantile nystagmus can be related to a sensory defect along the anterior visual pathway, or less commonly it can be idiopathic, where there is no apparent reason for the nystagmus. Manifest latent nystagmus is nystagmus seen in the presence of a childhood manifest squint, and it is associated particularly with infantile esotropia. Acquired forms of childhood nystagmus, such as spasmus nutans, are rarer and will be covered in greater detail later in your course. Adults might acquire nystagmus from lesions to certain areas of the brain, which could include, for example, the vestibular nuclei and the cerebellum. Lesions might result from traumatic injuries, diseases such as multiple sclerosis, or tumours within the brain, or from drug toxicity, for example as a side effect from taking lithium, which is used to treat bipolar disorder. As orthoptists, we use a classification system to describe the nystagmus, which could provide a clue as to the location of any brain lesion. The classification system on these slides has been lifted from Ansons and Davis and are here for your reference. Your lectures later on in the course will go into this in greater detail. But to summarise some of the main points, nystagmus can either be described as jerk, where the eyes appear to beat in a certain direction, or pendular, where the eyes drift away from fixation and back again without any change in velocity. There will be videos on some later slides which will help illustrate these movements. Many forms of nystagmus appear in the primary position and are present no matter where the patient is looking. However, some forms only appear in particular directions of gaze depending on the area of the brain that is affected. The plane of the nystagmus movements can be horizontal, vertical, torsional, or a combination. Horizontal and vertical nystagmus can combine to produce an elliptical movement. Most nystagmus involves the same direction of movement in each eye. Nystagmus with disjugate movement is rarer, however there are a few types, which you will come across later in your studies. In jerk nystagmus, the direction of the beating movement can also indicate the location of brain lesions and is important to be noted. There are notations to describe the frequency and amplitude of the nystagmus beats. Multiplied together, this is referred to as the intensity of the nystagmus. The direction and intensity of the jerk nystagmus can change depending on where the patient is looking. The intensity can also be affected by several other factors, including fixation, occlusion of one eye, or convergence, but also by emotions such as anxiety. It is also important to note symptoms such as vertigo and nausea, which could indicate damage to the vestibular regions of the brain. Here we have some animations that shows how nystagmus might appear. I've chosen to show forms of nystagmus that occur in one plane of movement, But as mentioned before, you may find that patients have a combination of more than one plane. First, we have pendular nystagmus. This example shows eye movement of a small amplitude but constant velocity. There is no fast phase of movement, so it is pendular rather than jerk nystagmus. In acquired cases, horizontal pendular nystagmus is most commonly caused by multiple sclerosis. The rest of the examples are of jerk nystagmus. The example of horizontal jerk nystagmus shows that the fast phase of eye movement goes to the patient's right, so the direction of the nystagmus is termed right beating. Horizontal jerk nystagmus can be seen in combination with a pendular waveform in infantile nystagmus, although it can also present in more sinister acquired cases too. There are also examples of vertical jerk nystagmus. Upbeat nystagmus has the direction of the fast phase going up, and vice versa for downbeat nystagmus. Both types may be seen in acquired nystagmus, where brain damage is located at vestibular nuclei or caused by drug toxicity. The last example here is of torsional nystagmus. As you can see, the eyes both rotate clockwise and jerk back anti-clockwise. In clinic, the easiest way to spot this is to look for torsional movement of prominent blood vessels. Again, this type might be a component seen with a vestibular cause of nystagmus. Management will be discussed in much more detail later in your course, but I'll provide a very brief overview here. When managing nystagmus in children, the main aim is to improve visual acuity. Therefore, a refraction and treatment of any amblyopia, as with any other amblyopic patient, should be done, although it is worth bearing in mind that pharmacological blurring might be better used if the intensity of the nystagmus increases when they are included with a patch. Contact lenses might work better for older children, particularly if they have an abnormal head posture, so that they can continue to look through the centre of the lens. If the intensity of the nystagmus can be reduced, then this can also improve the visual acuity. This might be achieved through the use of drugs such as gabapentin and mermantin, base-out prisms over each eye to stimulate fusional convergence if appropriate, Botox or surgery, which might involve recessing or detaching and reattaching all four horizontal rectus muscles. A head posture might be adopted because this is where the nystagmus is the least intense, known as the null point, and the patient can maximise their visual acuity in binocular single vision. Prisms can shift images so that the patient looks using their null point without having to adopt a head posture. Surgery can also eliminate head postures and can also be combined with performing strabismus surgery in a single operation. In adults, the aim is also to improve visual acuity. Depending on the type of nystagmus, the drugs used may differ, but surgical options remain the same as in children. In acquired cases, it will be vital to treat any underlying disease. Adults with acquired nystagmus might also appreciate diplopia if the brainstem disease has affected the ocular motor nerves causing strabismus. The management of acquired paralytic strabismus is the same in these patients as in those without nystagmus. The other part of this resource will talk about the work that a group of us involving staff and students have done following meeting nystagmus patients and family members at the Nystagmus Network Open Day in 2015. These open days are used where people affected by nystagmus or others with a personal or professional interest can meet to help raise awareness of important related issues. The links provided show some of the charity's web pages, and there is also a link to a newspaper article about Richard Osmond, who presents TV's Pointless, who also has nystagmus, where he talks about how it has affected his life. We attended the open day with two projects in mind. We wanted to ask patients and their family members questions on what it was like to live with nystagmus and the daily struggles they faced, and also what they thought of current patient care and what they would like to see improved. One of the projects focused on living with nystagmus as seen from the patient's perspective. Our motivation for this project was due to the need for a greater explanation of the patient's day-to-day visual functioning, rather than placing all the emphasis on visual acuity scores taken in clinic. Such qualitative reports are becoming increasingly used in research, as you can see from some of the quotes taken from McLean et al. This summarises some of the most common concerns of nystagmus patients, which was reported in McLean et al., along with a description of the cohort. As you can see, nystagmus places many restrictions on people's lives. The list is not exhaustive, and many more issues were pointed out. The reference for this paper is given at the end of the PowerPoint, and it's worth getting a copy. After talking to people at the Open Day, we identified 6 key themes listed here, which are illustrated further on the next slide. One of the themes was mobility and navigation. Patients can find it more difficult in stressful and busy environments like train stations and supermarkets, causing anxiety and making the nystagmus worse. Problems with social interactions was also a theme. Patients felt awkward at not being able to recognise people they knew when walking past them, which could cause the other person to get the wrong impression of being ignored. The people we spoke to also thought that public knowledge and understanding of the difficulties associated with nystagmus was poor in general, causing feelings of helplessness and isolation. People felt that the use of smartphones and tablets was one of the most positive impacts on daily life to occur recently, due to the benefits of being able to enlarge text and images on an illuminated screen. Patients were keen to point out that the intensity of their nystagmus and visual function can vary during the day, for example getting worse with tiredness and hunger. It was evident that nystagmus and visual impairment had a big effect on confidence and self-esteem. Some patients found it difficult to know what to say to people about the condition and difficult to ask for help. Other points within the themes we identified included patients' struggles with crossing roads and the reliance on low vision aids, distinctive landmarks and well-lit environments to aid navigation. One patient remarked to me that they much preferred being given directions with reference to striking landmarks, for example, being told to take the road after the red pillar box rather than being told to take the second road on the right. Other concerns patients had with social interactions included the time required to identify people, objects or landmarks and the difficulty of doing this in busy environments. Patients also felt they were restricted with hobbies and sports they could participate in. For example, the parents of one child with nystagmus said they had to give up their karate lessons because it was too difficult for them to see and copy the moves of the instructor. Other reports from patients discussed how other people try to help them but still have no understanding of the condition, and spreading greater awareness about nystagmus was clearly needed. People felt that access to technology and being able to use technology in different environments was important to them. The availability of audio information can significantly improve accessibility, for example notifications of place names on public transport. There was some opinion that the use of technology, although extremely beneficial, was not perfect for the nystagmus. Some said that different viewing positions were needed for different devices in different environments, and some screens are too big. There was a preference for smaller screens where users could manipulate the size of text and images with the zoom function. Patients and families wanted recognition that their needs and the type of support required will change over time, as a child progresses from primary to secondary school, for example. They also wanted recognition that because patients' visual demands change over time, this makes access to visual material harder and access to suitable lighting more important. Parents of children with nystagmus often felt that they had to fight for their child's educational needs within the system, causing much frustration. Patients also discussed how they needed to gain a lot of confidence before using low vision and mobility aids in public, due to feeling self-conscious. These are some of the quotes we noted from children with nystagmus, which often highlighted how technology is becoming increasingly useful for them. These quotes from adults illustrate some of the daily struggles these patients face, particularly with social interactions and public understanding. Quotes from parents referred to adaptations made to accommodate their child's nystagmus and also their sense of frustration at aspects of care and the lack of public understanding. The second project we took to the open day looked at how we could improve the patient experience in light of the lack of general awareness and understanding of nystagmus. Patients and family members reported to us that there was a lack of support, information and a standardised service. Some reported that they had a positive experience attending the eye clinic and that the eye care team did understand their condition, but it was a recurring theme amongst the people we spoke to that greater awareness is needed as to how the condition impacts the daily lives of patients. The age of the patient was felt to be important, with information and support tailored accordingly. Information leaflets was a strong recommendation. This slide collates all the recommendations from the open day regarding where service, information and support could be improved to enhance the patient experience over various aspects. As a result of the open day, we suggested that a standardised information pack be produced for both healthcare professionals and members of the public. This would include information on what nystagmus is and its effects on daily living, as well as links for further support and guides for teachers. The links in this slide will take you through to some areas of support already provided, for example what happens once someone is registered as visually impaired, and also vision standards for driving.